Hi, everyone. My name is Dr. Taylor Lara. I'll be joined shortly by my partner, Dr. Jonathan Vaux, and we're both joint replacement specialists at the Center for Joint Preservation and Reconstruction here at St. Alphonsus Medical Center. And this is going to be a presentation about common causes of hip and knee pain and surgical treatment of certain causes of those knee pain, hip and knee pain symptoms, with special focus on hip and knee joint replacement. So today we're going to cover kind of the basic anatomy, just getting the lay of the land of what's going on inside the hip and the knee. We'll cover common causes of hip and knee pain with special focus on osteoarthritis, which is the most common reason that we do hip and knee replacements. We'll talk about non-operative management as well as surgical treatment. And specifically, we'll cover who is a good patient for hip and knee arthroplasty, what is it, what to expect, and what to look for as you're seeking treatment, and some resources for you that you can take no matter where you get your treatment. Just starting with the basic anatomy, starting on the left with the hip. The hip, like all joints, is where two bones come together, and they have a smooth gliding surface, which is covered with cartilage, which gives you a low friction and well-functioning joint. So on the left with the hip, you can see that the hip is the intersection between the femur or thigh bone and the pelvis. As you may have heard, it's a ball and socket joint, and you can see that I'm sorry, does the mouse pointer show up here on the screen? Yes. The main part of the thigh bone, sorry, I'm pointing to the main part of the thigh bone here, which is connected to the neck of the femur, leading to the head of the femur. That's the ball and socket joint of the hip joint. And the socket is called the acetabulum, and that's part of the pelvis. And this is also surrounded by a joint capsule, which lends stability to the hip joint and creates the joint fluid inside the head. Moving on to the knee here, this would be a right knee. So this is the lateral side or outside of the knee. This is the anterior or front portion of the knee. And the knee is the intersection between the femur or thigh bone and the tibia or the shin bone. The major muscle on the front of the knee is the quadriceps muscle, and that provides us strength to straighten our knees. And the patella or kneecap is the bone that exists within the tendon of the quadriceps muscle and helps as a lever to help straighten the knee. I like to think of causes of hip and knee pain as being in two major categories, and those are one, problems that are inside the joint, and then problems that are outside the joint, but frequently mimic problems that are inside the joint. And we'll cover both of these topics in the hip and the knee. So first, let's talk about the stuff happening outside of the joint. These are things that are frequently mimics of hip and knee osteoarthritis, and we're often considering these diagnoses when somebody comes in with hip or knee pain. So for the hip, the major culprits outside of the hip joint are trochanteric bursitis or greater trochanteric pain syndrome. You can also have pain that originates from the spine or from irritation of nerves or so-called sciatica, which can cause symptoms around the hip, even though it's not coming from the hip itself. With respect to the knee, we often see iliotibial band syndrome and patellofemoral pain syndrome, and we'll discuss those in detail. So first, talking about trochanteric bursitis. The bursa is basically a sac of fluid that exists on the outside of the hip joint. You can see this is the hip joint itself. This is lateral to the outside of the hip joint. And this is that bony prominence that you feel when you touch the outside of your hip with the lateral aspect of your hip. It's called the greater trochanter. If you're lying on your side and you feel that bony prominence on the side of your hip, that's what you're feeling. The bursa rests on top of the greater trochanter and is supposed to prevent friction between the greater trochanter and structures on top of it, namely the iliotibial band. The trochanter itself, or the trochanteric bursa itself, can become inflamed and painful, and is often manifest as tenderness on that aspect of the hips. And this is the real, this kind of nails the diagnosis almost every time. When you have tenderness or pain when you press on that aspect of the hip, that is often extra-articular pain or pain from outside the joint. Hip arthritis pain is usually not tender to palpation. This is usually felt in the outside or lateral aspect of the hip. This is caused by stiffness or tightness of the iliotibial band, which is a large tendon-like structure that goes on the outside of the hip, and also a weakness of the muscles around the hip, particularly abductor muscles, and those are muscles that allow you to move your abductor hip, meaning allows you to move your leg out towards the lateral portion of your body. And also altered gait. People who've had a chronic limp often get this type of a problem. Treatment for this really centers around physical therapy. Correcting that tightness of the iliotibial band and the weakness of the abductor muscles is ultimately what cures this. Sometimes we consider injections as sort of an adjuvant treatment or a supplemental treatment to help physical therapy go better. But I think the real mainstay of treatment for this is physical therapy. It can be a very annoying diagnosis because it can take a long time to go away and there's no quick fix for it. So we do a lot of what I call cheerleading or trying to keep your spirits up as we're getting through this diagnosis. But it does respond well to therapy if you stick with it. Next is sciatica. This is a term that really just means leg pain, but specifically we're referring to pain coming from compressed or irritated nerves originating in the spine. And then this is a representation of the spine from the neck down to the lumbar region. And this enlarged area here shows us the vertebra or the main part of the spine, the discs in between the vertebra, and then the yellow tube-like structures you see there are nerves exiting the spine, which provide sensation and motor function to the legs. Things like a herniated or bulging disc or arthritis in the joints in the posterior portion of the spine called facet joints, those can lead to compression of those nerve roots and irritation of them. This is manifested as pain that shoots usually all the way down the leg and can have a sharp but also burning or tingling sensation associated with it. Sometimes we refer to this as pins and needles type pain. And often when we're talking about pain that starts in the back or buttock, it goes all the way down to the foot. This is almost always originating from nerves rather than the actual bone and joint structures around the hip. There's a lot of causes of this. You can have compression or just inflammation of the nerves, and treatment for them can range from everything from anti-inflammatories to surgery. And often we may get you started on the treatment path for this, but often we want to get you over to a specialist in the management of problems of the spine, whether it's a surgeon or a non-operative doctor, to get you appropriately treated for this. And sometimes they need to have additional imaging before considering more invasive treatments, such as injections and potentially surgery. Iliotibial band syndrome is a source of pain around the knee that it's kind of the cousin of trochanteric bursitis because it shares a common structure as a culprit, and that's the iliotibial band. This is a better representation of that. You can see that it originates at the side of the hip, the crest of the ilium, and extends all the way down and connects on actually the tibia or shin bone on the distal aspect of the knee. The red area here is the area that tends to be painful, and this is another high friction area that can become irritated with an associated bursa underneath it. Just for reference, that's the greater trochanteric bursa that we were talking about earlier, right over the hip. Just like trochanteric bursitis, this is often manifested as tenderness on the lateral portion of the knee. And again, this can be caused by stiffness and tightness of the iliotibial band and muscular weakness of muscles around the hip and the knee. And all people with altered gait or a chronic limp often have this problem. Mainstay treatment for this is physical therapy again. Sometimes you do consider injections, but again, they're more of an adjuvant to physical therapy than a cure-all on their own. Patellofemoral pain syndrome is something we see quite often too. This is this is kind of a category of diagnoses, but the basic problem that we see in patellofemoral pain syndrome is represented in these MRI slices. These are representations of the knee. This is called an axial view, or slices of the knee in the axis of the body. So this is the distal part of the femur, and this is the kneecap. And this is as if you're looking down at your own knee. This is what you would see if you could see basically through all the structures. This is sort of a normal knee with the patella tracking in the center, in the central area. And then on the right, we see this patella is tracking laterally to the outside of the body. There's a lot of forces pulling the patella this way. And if we get weakness of parts of our quadriceps muscle, or if we have anatomical differences in the ways that our bones and joints are aligned, it can really exacerbate this problem. So you get a lot of pressure on this side of the patella, the lateral side. That cartilage can become soft and irritated. Even though it doesn't go on to full degeneration and osteoarthritis, or even though it can at some point, usually patients that haven't gotten to that point, they can make quite a bit of progress with quadriceps strengthening, possibly therapy, and sometimes injections. This tends to be sort of a reversible process at this point. So the hallmark symptoms of this are anterior knee pain or pain at the front of the knee. It is usually manifested with going up and down stairs and with prolonged sitting. We used to call this the feeder sign, or your knee would hurt after sitting watching a movie for an hour and a half. As we discussed, this is usually caused by quadriceps weakness, but also some anatomical problems can contribute to it. And therapy is the mainstay of treatment here. And then, just to be perfectly clear, usually X-rays in this case don't show signs of arthritis. There's well-preserved joint spaces, and we'll go over that more in just a little bit. Now, getting on to the meat of the presentation, osteoarthritis is the main problem we treat inside the joint. This is the most common form of arthritis, although there are other types, including inflammatory arthritis or so-called rheumatoid arthritis. But this is really the vast majority of what we see in our clinic. Causes of this tend to be age-related primarily. This is a very common disease in older people, although we do see it in younger and younger people. Genetics play a role. If both your mom and your dad had hip and knee replacements, there's a good chance you might need one too at some point. And there are some metabolic factors, excuse me. In particular, poorly controlled diabetes can contribute to chronic inflammation all over the body, but in particular can affect the hips and the knees. The way this disease works is that the cartilage that we saw before, that's when it's intact, it's pristine and has very low friction, glides very smoothly. That cartilage breaks down, and although you don't feel the cartilage breaking down, at some point the bone underneath the cartilage becomes exposed, and then your body knows something's wrong. It starts to trigger an inflammatory reaction. It's that inflammation that leads to pain. Like I said, you don't feel the cartilage breaking down. Cartilage doesn't have nerve endings in it. It's when the joint has gotten to the point where it's getting inflamed that is when it starts to hurt. So as a result, we have people that have been asymptomatic for years, and then things tend to get triggered by a minor injury or overuse. People say, oh, I was gardening all day and then my knee got swollen and started hurting and it just never calmed down. Or, I was playing racquetball or pickleball, excuse me, and my hip started hurting and it just never felt any better. And we take an X-ray and it looks like they've had arthritis for years, but very common thing for us to see. And we'll go over pictures of that. So it's just a cartoon representation of the process of osteoarthritis in the knee joint. And here we see the smooth, intact articular cartilage on the end of the femur. The menisci are intact here. And then they have what we call a normal joint space. And we'll see what that looks like in an X-ray. In the process of osteoarthritis, you can see the cartilage is lost from the surface of the bone. So the bone underneath the cartilage is exposed. And as a result of that inflammation, the bone starts producing more bone, or what we call bone spurs or osteophytes. And we'll see joint space narrowing more clearly on the X-ray examples in just a second. But also notably absent are the meniscus now. Lots of people will get an MRI of their knee, and lots of people over 50, if you get an MRI of the knee, you're going to see meniscus tears. But it's often as a result of the process of osteoarthritis rather than a separate disease or injury. So I have this conversation with people a lot. Ask me, do I need an MRI of my knee? And I'm looking at an X-ray with bone arthritis, and I always tell them no. We see everything that we need to see. and an MRI is not necessary. Excuse me. I apologize. I'm getting over a cold, but I'll try to keep my coughing to a minimum. But yeah, they'll often ask me, do I need an MRI of a knee that has arthritis? And I usually tell them no. We're not going to try to fix a meniscus tear that's been, a degenerative tear associated with arthritis that's been there for years. It's just not going to be amenable to repair. We're usually talking about other types of treatment rather than that. So this is what we see on the X-ray. Excuse me. On the left here, you see an X-ray of a knee that has a normal joint space. Cartilage and meniscus don't show up on X-ray, so it looks like there's empty space between the femur and the tibia. And once people have gone on to develop arthritis, and this is a fairly severe event here. Oh, thank you. You see that joint space has been obliterated. The bones are now touching each other. You see these bone spurs or osteophytes here. And you can also see that the bone has become more bright white, right at the border of the joints. That's called sclerosis. That means that the bone that's been exposed from underneath the cartilage has gotten denser and harder in response to that loss of cartilage. And here again, we see, sorry, the picture got cut off a little bit, but I think you can still see basically what you need to see here. Again, this is an intact hip with normal cartilage on both the head of the femur and the acetabular socket. And here you can see that the cartilage is worn away. There are bone spurs forming, joint space has been narrowed. And then this is very clear here on these X-rays. You can see here a normal joint space with space between the femoral head and the socket of the acetabulum. And on the opposite side, you see that space has been obliterated. There are bone spurs forming, and this is a very common thing that we see. It's a cam lesion, or an area here where there's a little extra bone. You see how this femoral neck is nice and smooth. It looks like an hourglass, and here it looks like there's a hump here. And this area of bone was probably contacting the rim of the acetabulum and started the process of arthritis through a process we call impingement, or this part of the femur bone contacting that part of the pelvis and kind of starting tears in the cartilage, which eventually became full-blown osteoarthritis. All right, so the main symptoms that we see in hip and knee arthritis is activity-related pain. In the hip, we usually see this as groin and deep buttock pain. It's usually not on the lateral side or outside of the hip. We usually feel it in the groin or deep buttock. A lot of people think they have a hernia or a strained groin muscle, and are only diagnosed with arthritis once they have an X-ray taken. Hip pain can radiate or shoot to the thigh or even as far as the knee. It usually doesn't go past the knee, though. If the pain's going past the knee, we get much more suspicious of sciatica. Stiffness is a major issue in advanced osteoarthritis of the hip, and a lot of people complain of trouble getting on shoes and socks. People can walk with a limp, and sometimes we have leg length inequalities. One hip might feel, or one leg might feel shorter than the other. And this can either be from the loss of the joint space, literally shortening the extremity, or because of stiffness causing contractures or basically not being able to fully straighten your hip, which makes it feel like it can't reach the ground. In the knee, we're also seeing activity-related pain, and this can be anywhere in the knee. It's often on the side where there's the most wear, and typically there's more wear on either the medial or inside or lateral or outside portion of the knee. And of course, you can have stiffness as well. A lot of people complain of loss of range of motion, particularly inability to fully straighten the knee is very common. You can also have a limp, and we also see deformities. So lots of people say, oh, I feel like I'm bow-legged, my knees won't touch each other, or they're not kneed, and that my knees rub against each other when I walk. And then this is just a representation of that. So in a normally aligned knee, you can draw a line from the hip through the center of the knee, through the center of the ankle. If somebody has a not knee deformity or a valgus deformity, you can see that the knee joint bows towards the midline of the body, as that line falls out to the lateral portion or outside of the knee. And in a bow leg or varus deformity, this is the more common of the two. that line's going to fall inside of the knee. So the knee actually bows outward. Non-operative treatment. Non-operative treatment is really important. We don't want to jump into surgery with everybody because some people get better without surgery. And then mainstay treatments are non-steroidal anti-inflammatory medications. As we said before, osteoarthritis is a disease ultimately of inflammation, and anything that we do to control pain is ultimately just to deal with inflammation. And that's true whether we're taking an ibuprofen or if we're doing a knee replacement surgery. Ibuprofen and Aleve, or ibuprofen also known as Advil, or naproxen also known as Aleve. Those are the main over-the-counter oral anti-inflammatories that are available to people. Excuse me. Some people are unable to take oral anti-inflammatories due to heart or kidney issues, or because they're on blood thinners, or have a history of ulcers or bariatric surgery. And so a good option for those people can be a topical anti-inflammatory. This doesn't work so great in the hip for hip osteoarthritis, but it can work around the knee because that structure is just more superficial and there's more likely for the medicine to get from the skin into the joint. This is called topical diclofenac, also known as Voltaren gel. It was prescription only until about a little over a year ago, but now it's available as an over-the-counter product. Healthful weight loss can be really helpful. If you're doing this with a proper diet where you're not becoming, you're eating adequate healthy protein, lots of vegetables. If you lose some weight doing that and doing moderate exercise, that can be very, very helpful. It can reduce inflammation, and your joints act sort of as a lever arm. So if you your hip during normal walking will see twice of your normal weight, body weight, each hip as you're walking. And the knee can see 4 times the force of your body weight during normal walking. So if you lose 10 pounds, that might be 40 less pounds of force through your knee, and you can see why that might be something that helps your symptoms quite a bit. Bracing is something we consider for knees. I'm a little bit plus minus on them. I help people try them if they think it might be helpful, but it doesn't really change the disease of osteoarthritis. It can help with symptoms in some people. Gait aids like canes and walkers are very common for people to try. Some people lean on shopping carts. That's something I always try to ask about. Therapy does have a role, making sure joints are really strong, or the muscles are strong that across the joints can help support those joints and optimize people's symptoms. And we do talk about injections, both in the hip and the knee. Knee injections are very easy to do, so we're more prone to try them because generally pretty low risk and very well tolerated. Hip injections being a little bit more challenging. We typically have to send you to one of our partners that does those injections under ultrasound guidance, as it's a deep structure, and there are pros and cons to it that we'll discuss with you if that ever comes up. Things that we should really be careful about. I always caution patients about avoiding these treatments, and we do see these treatments prescribed sometimes in the community. But I think probably the biggest one is opioids. I don't think anybody should be taking opioids for hip and knee arthritis. This used to be considered okay by our main governing body, the Academy of Orthopedic Surgeons, but they've since retracted that. They made an exception for tramadol at one point, but if you're needing to take opioid medication for hip and knee pain, I think it's something you should at least talk to a specialist about, because if it's really that bad, you should be talking about things like injections and surgery, in my opinion, or at least considering them. Activity restriction. I get this question all the time. Am I going to make this worse by exercise? And the answer, I think, is pretty resoundingly no. We got good studies of marathon runners, and they don't get hip or knee arthritis any more than anyone else. And there's even some evidence that people who initiate weight-bearing activity and exercise, even after they're diagnosed with osteoarthritis, can actually have an improvement in their symptoms. So I think the take-home message from that is weight-bearing activity is good for your joints. You can definitely irritate them, you can definitely overdo it, but you're not going to cause long-term damage. That's a process that's set in motion that's usually independent of most people's actions outside of having a fracture through their joint or having a major ligament tear. And then just a good rule of thumb for me is I would just be really careful about anything that's cash pay. If they're saying, you know, we can inject something in your knee that's going to regrow your cartilage and you just have to pay us $2,500, I would view that with a lot of suspicion. Insurance companies annoy us with a lot of stuff. We don't like them for a lot of reasons, but one thing they do pretty good is they look at the evidence basis for certain treatments. And if they're refusing to pay for a certain treatment outright, it's probably because there's not a great scientific basis for that treatment. And I just hate to see people pay a lot of money for something that doesn't have good evidence behind it. All right, now moving on to surgical treatment. The goal, like we said, is to reduce inflammation and pain primarily. We also, especially people with very advanced arthritis or deformities with the knee or hip, we want to restore the normal joint mechanics. And we do this by providing a new bearing surface, which is usually some combination of highly durable plastic, metal, and ceramic. And basically what we're doing in either procedure is replacing any remaining cartilage and any diseased bone with prosthetic implants. And we'll go over each one. This is sort of an outline about a hip arthroplasty works. We have the basic components here. There's a femoral stem that goes inside of the femur after the femoral head and neck have been removed. That's connected to a replacement femoral head. An acetabular socket or acetabular component is impacted into the bone of the pelvis. This has a roughened surface on it that the bone can grow into. And then a plastic or ceramic liner is locked into that component, and that completes the arthroplasty procedure. We have a nice cartoon showing the femoral head and neck being removed, the acetabular socket being impacted into place with its corresponding plastic liner being locked in, and then the femoral stem is inserted and the replacement head is placed on the femoral stem. This is kind of shown independent of approach. There's lots of ways to get in the hip. We'll talk about that a little bit later. But the goals of the surgery are the same regardless of how you're getting into the hip joint. You want to have well-positioned and well-sized components placed in such a way that they're stable and they restore the mechanics of the hip joint. And this is just a before and after of x-rays of an arthritic hip and then a hip that's been replaced with a hip replacement as we just saw. So this is the acetabular socket. The head rests within the acetabular socket. It's a little bit hard to see there. And then the neck leading to the femoral stem inside the femur after the femoral neck and head have been removed. For knee arthroplasty, same basic concept. We're replacing the bearing surfaces of the knee. And of course, we see the arthritic knee here. A femoral component usually made out of metal, typically cobalt and chrome alloy, is placed on the end of the femur. The tibia, a flat cut is made across the top of the tibia, and typically a metal tray is implanted in with a keel on it, sort of like a boat, and a plastic liner is locked into the tibial component to glide smoothly on the femoral component. And then this is just a different viewpoint of that. What I like to point out here is that you can see that the femoral component is curved. So we're not lopping off the end of the femur. We need to preserve your collateral ligaments, like the medial collateral ligament that we see here. That's what's going to provide stability to your knee after surgery. So we make 5 cuts around the end of the femur to help approximate that curvature. So we're just replacing the minimum amount of bone, just about 9 or 10 millimeters of cartilage and bone. So it's more like a resurfacing procedure rather than replacing large amounts of bone. And then arthroplasty, who is it for? Early in my training, I got some really good advice that, you know, it's amazing how well patients do when they get the right surgery. I was really confused by that at the time, but I started to understand that the, being a good surgeon is great, but if you have good indications, meaning that the reasons you're doing the surgery are correct, and you've got the right patient, right surgery, even an average surgeon will get a good result in those scenarios. A great surgeon will not get a good result if they're doing a surgery for somebody who shouldn't be getting that surgery. That's just never going to work. So the ideal candidate for arthroplasty are patients with moderate to severe osteoarthritis on X-ray. It doesn't have to be necessarily bone on bone, but there are clues on the X-rays that tell me that there's complete cartilage loss in at least some areas of the joint. These patients have daily symptoms which limit the activities of healthy living. Certainly, if you're not able to walk around the block, it's going to be hard to get the minimum amount of cardiovascular exercise to keep your heart healthy. And most times we want to look for at least 3 months of trying some sort of non-operative treatment, even if that's just a home exercise program, or activity modification, and taking some Advil. That would certainly qualify. And then we want to try to optimize some risk factors if possible. This can be difficult, but anytime we can do something to reduce your risk of having a complication after surgery, we really try to do so. Some of the main things we look at are control of type 2 diabetes, usually evidenced by a hemoglobin A1C of less than 7.5. One thing that we're fairly hard on is abstinence from tobacco and nicotine. Cigarette smoking in particular, and use of nicotine in general is a leading modifiable risk factor for infection. And these are potent, we call vasoconstrictors. They cause our small blood vessels to really contract and make wound healing much more difficult. And when wounds don't heal, that can lead to infection. And as we'll find out, infection after total joint replacement can really be a disaster. It's not common, and we treat a lot of infections, usually not from surgeries that we've done, but patients that have been referred to us. But it is something that everybody wants to avoid. And then we do consider healthful weight loss strategies if we have a BMI or body mass index over 35. And we work with a team of nutritionists to give you good advice on how to optimize your diet prior to surgery. And everybody that I referred to for this, even if they were skeptical at first, really feels like they got some really good advice and identified some patterns in their diet and behavior that could be really leading to lots of problems for them. And my partner here, Dr. Vaux, we originally planned for him to do the first part of the presentation, so I'm just going to ask him, do you want to join time in for the rest of it? So I'll give him some time to talk. He's a great guy, and I'll give him the podium. And I forgot to mention earlier, if you got questions, just put them in the chat and we'll address them at the end. And yeah, we'll look forward to hearing from you. So here's Dr. Vaux.
All right. Thanks, Dr. Lara. Sorry, I was held up in the operating room actually, but I just wanted to say thank you. My name is Dr. John Vaux. I recently relocated here from the Seattle area and joined the joint reconstruction team. So excited to talk more and kind of carry on where Dr. Lara left off about what exactly is hip and knee arthroplasty, more specifically, who is a good candidate for it. So we talked about, Dr. Lara mentioned that, like who is a good candidate. And then it's also really important for us to talk about who are patients that it's not right for. And so not infrequently, we see patients who are referred to us who were told by someone that they need a knee or a hip replacement. And I think it's imperative as your physician and your provider that we also educate you when surgery is not that option. So patients that we would say that should avoid joint replacement would be patients with minor or occasional symptoms. This is really something to relieve those daily type pains. Not that we want you to suffer, but the day-to-day daily activities that is constant. Patients that have mild findings on X-ray of arthritis, if you don't have radiographic evidence of arthritis like Dr. Lara showed, then a joint replacement is not going to be for you. Patients that are expecting to return to high impact activities or high level sports, this is extremely important. We talk all the time that I tell patients that we are giving you a new knee, not a normal knee. And so our goal is to decrease your pain and increase your function, but this is not going to be the knee that you had when you were 20 years old and able to kind of do whatever you wanted in that regard. And then patients that are under 50, we can talk about age and joint replacements later, but really, if you're less than 50, we try our best to try other options. That's not to say that it's out of the question if you meet those criteria, but certainly that's something we need to have a really thorough discussion with, and then particularly as it relates to knee replacements. So everybody always asks, what is the post-op recovery? So what am I looking at? How much time more off work, all those sorts of things. And so on the day of surgery, our goal is for you to be walking a weight bearing as tolerated. I would say that pretty much every patient that has a primary joint replacement is walking and full weight bearing on their joint right away. We have you work with physical therapy immediately after surgery. That's done in the hospital to ensure that you're safe, that you're mobile, and that you're able to go home. We ask you to use a walker initially for a few days at least, and then transition to a cane whenever you're ready. This is really to prevent you falling and breaking something or injuring something else. And then improvements in pain and function can continue for really up to like 1 to 2 years after. A lot of times we say that you don't have a maximal improvement until even 1 or 2 years after surgery. You can continue to see gains in strength and range of motion and your walking ability. One of the things now you may have heard of some people who have had outpatient joint replacement surgery or same day discharge joint replacement surgery. With a lot of the advances in our multimodal pain regimens and the collaboration that we have here, we're able to send patients home the same day of surgery. About 80% of our patients go home the same day. This is obviously something where we make sure that you're very safe and able to do that at home. The rest of our patients stay about one night and then go home the next day, but we really try to discourage inpatient rehab or a nursing facility. A lot of times it's not necessary, and it can actually, there's been a lot of studies that show worse outcomes. It's really important for us that we have a multimodal anesthesia. Most often you'll get a spinal anesthetic, and then we use a variety of different pain medications to really help control your pain from different aspects. And then there's a huge collaboration, which we'll talk about later, with our whole team, whether that's nursing, anesthesia, the preoperative clearance clinics, therapy postoperatively, our office staff, and that's really important to having a smooth recovery. Looking specifically at the recovery of hips and knees, if you have a hip replacement, you may have heard of somebody having hip precautions or range of motion precautions. This is to allow your capsule to heal in, and because of the risk of dislocation. Typically, your hips do a little bit better than knees, meaning that they feel better sooner. So about 2 to 6 weeks after surgery, you can even start to feel quite a bit better than before surgery. If you're wanting to return to a high, like labor-intensive type job, we're really looking at something around the time frame of 3 months. Obviously, that's individualized for each patient. And then driving is about 3 to 4 weeks, particularly, or I should say, and that's for your driving leg. Knees, we don't have any range of motion precautions. Typically, it takes a little bit longer, and that reason is because knees can be a little bit stiffer and sore. So we have you work with therapy to really work on the bending and the straightening. You can even continue to see some swelling for even 3 to 6 months after surgery. And sometimes that means that higher demand jobs takes more like 3 to 6 months to get back to. So obviously this is a major surgery, and all major surgeries have risks. And so some of those major risks that we want to talk about and to make sure that you're aware of are listed here. We'll go through them, but keep in mind that this is really only about 2% of the time. But if they do happen, they're an unfortunate consequence and complication that we need to be aware of. So infection, Dr. Lara kind of alluded to this. It's a very serious complication if you get an infection in a joint replacement because of metal that's in there, and often this requires, or vast majority of the times, will require multiple surgeries, one, maybe more surgeries, and an extended period of IV antibiotics and sometimes oral antibiotics. A dislocation can happen. Your hip joint is no longer tethered by the and held in place by the capsule after surgery, and so there is a risk of dislocation. And we talk with you about some positions to avoid after surgery, particularly for the first few weeks. Knees have a tendency to get stiff, and so we work really hard with giving you some exercises before surgery and after surgery, and sometimes being very diligent about going to physical therapy. Any major orthopedic surgery, and particularly arthroplasty, has a risk of blood clots, and so depending on your history, we will put you on some sort of blood thinner for at least 30 days after surgery. Whenever we're dealing with bones, there's always the risk of fracture. Sometimes this can happen at the time of surgery. That's very rare, and if it does, we would address it at the time of surgery. But if you were to fall later for whatever reason, you can have a fracture around your implants, and that can require a repeat surgery. And then component wear or loosening, this used to be actually a major cause of revision. And I slide to the next one because the topic here is how long does it last? So one of the major causes previously was that the components would wear out. This is less and less common as our advances in materials have gotten better, but it can still happen. The components can still loosen. The plastic liner that Dr. Lara showed can wear out over time. You may need a repeat surgery to change out that liner. We think that most of our studies say that they last about 30 years or so, and knees last about 20 years. That's kind of ever evolving and changing. Obviously, that depends on the patient and their activity level. So some of the hot topics in total joints that you may have seen or heard about or talked about, or somebody may say, oh, you have to have it done this way or that way. We just wanted to shed some light on those and talk about those. So there's a lot of patients who are getting a robotic assisted or computer assisted navigated surgery. Those are great. And they have, but there is no proven benefit in the literature that shows that a robotic versus a non-robotic knee replacement or a hip replacement is superior to one or the other. Similarly, minimally invasive approaches, there's lots of people or surgeons who will say, oh, my incision is only so long. And there is some correlation when you get to a very long incision with the increased risk of infection. But the most important thing is that your wound heals. And so depending on your body habitus, you may have a longer or shorter incision. And the primary thing we want is for that wound to heal up nicely, so then you don't have any wound complications afterwards. Continuous passive motion machines or CPMs used to be very common and very popular after knee replacements to get your knee moving. And those have basically been shown that there's no difference in doing that versus home exercises or therapy. And cryo cuffs, this is very common in shoulder surgery, actually, if you've ever seen anybody with like an ice wrap over their shoulder. We used to do these for knee replacements as well, but there's really no proven benefit of that over a standard ice pack that you could get anywhere else. Our bottom line that we want to communicate here is that hip and knee replacements are extremely successful procedures, regardless of the technology or approach that is used. And the differences between different approaches are really quite small and insignificant. And we really would caution you to be aware of marketing and someone who's saying that, oh, you have to have a knee replacement done this way, or you have to have a hip replacement done that way, because this is the best. So moving on now, some things to look for in your surgeon. And this is really Dr. Lara and I's a little bit of opinion, but we think that it's important to help educate our community. And so some things that we would recommend looking for is a surgeon who listens well, who's going to perform a physical exam on you, someone who takes time to answer your questions. The common phrase is, what other questions do you have, is what we try to continue to ask, so that we give you the opportunity to ask questions. Is it someone that explains it in a way that makes sense to you, or is it just medical jargon and you have no idea what's happening? Someone that helps you make a decision rather than telling you what to do or what has to be done. The volume of the surgeries that they're doing, and also the training. So all of Dr. Lara and I and our partners, we all have extensive training, not only in orthopedics, but also in joint replacement surgery and complex joint replacement surgery. And this is what we do every day. And so our recommendation would be that you find somebody who does a lot of these types of surgeries, because that volume typically correlates with better outcomes. And then what happens if a complication occurs? Are they somebody who is going to take care of your complication if you have a complication, one of those 2 to 3% risk of complications, or are you going to get referred to a different surgeon? We also recommend that you be aware of these things listed here. Arrogance, if they're claiming to be the best, ask them how do they know that they're the best, right? Claims that they have a game-changing technology or approach, or this is the only way to do a hip replacement, or this is the only way to do a knee replacement. If they seem really short with their time, they don't meet you until the day of surgery. If they pressure you into a particular treatment or say that you have to do this, kind of like we talked about before, or if they're not listening or examining you. And then bottom line is trust your instincts. You need to be comfortable with a surgeon that's going to be operating on you, and you and your family members even. We also strongly believe that it's not just the surgeon, it's the whole team. So we have a whole group of an incredible office staff, advanced provider practitioners. We have nurses and MAs who help us in the office, and this is what they do every day is help us and our patients. The hospital and the surgery center, we are very aligned in how we do these joint replacements. And as we talked about, we have a medical team, we have a therapy team, we have the nurses, we have the anesthesiologists that are all there to help walk you through this process. And then also our partners. I think Dr. Lara and I would say that one of the best things about our job is who we get to work with, and that we all do a similar type of surgery, and we all are very collaborative in how we do it, but different in our approach. And I think that that's a strength to our group. As I talked about, just the strength of St. Alphonsus in general. And then our partners, Dr. Jenny Jin and Dr. Dennis McGee, are excellent. Dr. Lara and I, as much as we'd like to be available for you 24/7, and in reality, that's not possible. And so it's really important that we have great partners that we can trust not only with our patients, but with our own family members. So if you have other questions, we're going to have a time of questions, but also I feel strongly that looking on Google is not the greatest way to look for information about joint replacements. However, the American Academy of our Association of Hip and Knee Surgeons is where we are all members of, and is an excellent resource. If you want to scan this with your QR code to your cell phone or type in this web address, there is a lot of information and resources. There's exercises. You could even watch some surgeries if you really wanted to, but lots of really good information there. And we would love to open it up for questions.
Okay, so this question's for you, Dr. Vaux. What exactly are PRP injections?
That's a great question. PRP injections, and more specifically, is it just what are they or how are they used?
What are they?
Okay. PRP injections are platelet-rich plasma injections where they take a portion of your blood, they spin it down, and then they can give a portion of it back to you. And the thought process there is that it is, and Dr. Lara, please feel free to chime in or correct me if I'm wrong, but essentially trying to take your own cells and then regenerate cells within your joint or wherever they're being injected.
Right. Basically, yeah. And it's in PRP, the evidence for it varies depending on the diagnosis. I think that's the biggest thing to know. There's some applications for it that are probably much more effective than others. You are basically taking parts of the blood that have a lot of the inflammatory markers that actually cause the inflammation of arthritis. So it doesn't make a lot of biological sense for me to just inject that into an orthopedic joint and expect it to be better from that. There are, in my understanding of literature, is no better than steroid shots or other shots that are available to us. So we kind of keep that kind of far down the line. It's often cash pay. In some cases, our partner, Dr. Koontz, has done it with gotten insurance coverage for it. For those patients that really can't get surgery or surgery is not a great option for them, we keep it in reserve. But it's one of those things that, like I said, when we can't give you a paper saying it's better than a $5 cortisone shot, then I think it's better just to not have to pay out of pocket for something that's not proven.
Okay, and this one's again for you, Dr. Lara. My friend is fearful of having her hip replaced. What words of advice would you give her to set her mind at ease? Okay,
well, it's I tell people it's normal to be nervous before surgery, and the people who aren't nervous are the people that worry me more. I think just knowing, getting some. I think first thing is get a surgeon that you're comfortable with. They don't have to be a surgeon that does the fancy approach or uses robotics. Somebody who takes time with you to answer your questions, help you understand what you're getting into. Overall, hip replacement, it's been called the surgery of the century because it's just so successful. We measure that in quality of life years. So how much better is your life for how long? And that's actually a bigger benefit than cardiac bypass surgery. So if I had to get one surgery, it would probably be a hip replacement, and it's not just because I'm biased. But yeah, finding a surgeon that takes time with you, that you feel comfortable with. If they done the number I tell people to look for is about 60 surgeries a year of hips and or knees. So people who've done at least 60 hip replacements a year, they're usually going to do as good a job as even higher volume surgeons. So if you meet those requirements and you have the diagnosis, bona fide arthritis and symptoms every day, most people are going to do really, really well with hip replacement.
And Dr. Vaux, is there an age limit for hip replacement or knee replacement surgery?
That's a really great question. We kind of alluded to this earlier. I am not aware of an age cutoff, high or low.
Yeah.
What I would echo is some of what Dr. Lara just said, which is if you have symptomatic arthritis, if you tried the other things and it's not working, and not that we want you to be miserable, but that you can't do anything else and you're 45, I think a joint replacement is a totally reasonable complication with accurate expectations. What I see with younger patients is that they say, hey, it's good, it's better, but it's not great. And a lot of times that has to do with the activity expectations that they have. And then also the conversation of, we think these last about 20 to 30 years, your likelihood for a redo surgery, whether that be wearing out, you have more time to get infected or have a fracture or some sort of complication, that risk is going to be higher. But as Dr. Lara already said, the quality of life benefit might be there for you.
Awesome. And the next question is, can you repeat the A1C number you recommend for a good outcome for knee replacement surgery?
Okay, we draw a little bit of an arbitrary line because you got to draw a line somewhere. We generally say about 7.5. We can definitely get some benefit if we get you below that. But yeah, in our clinic, we've kind of said 7.5 is sort of the line. And that's a little bit on the higher side from other places that I've worked and trained.
And then the next question is, how often is it safe to get a cortisone shot? Twice a year, 3 times a year, too many?
Yeah, I usually say 3 to 4 months. Lots of places it's 3 months. In our clinic, we usually err on the side of 4 months. I think a lot of that's to be standard, especially in hips. We're a little bit more worried about complications from steroid shots, just because the blood supply to the hip is a little bit more delicate than to the knee. So we like to space those out a little bit more, just to be standard. We usually say that every 4 months, but you can twist my arm to 3 months.
The other thing I would add to that, if the questions that are there, and a lot of people don't know, is that if you've had an injection, you need to wait about 3 or 4 months after that before having a hip or knee replacement, because your risk of infection will be elevated.
That's true.
Yeah.
Do any supplements such as glucosamine, chondroitin, or MSM help?
That's a great question. My take on it, and I'd be curious, Dr. Lara's, is there's no proven studies out there saying that glucosamine does anything to help. However, it also can't really hurt. And so I generally tell people, try it, go get some, try it for 2 to 4 weeks. And if it doesn't help you, don't waste your money. But if it helps you, you can keep, there's no harm in taking it.
Yeah, and again, it's more of a cost thing. Like if whatever thing you do, if it's not hurting you and it's not, breaking the bank for you, I'd say more power to you. I think, and it's the same stuff that's in the end of a chicken wing, so you can feed that too. Those are pretty cheap. But yeah, I don't have good evidence that they're effective, but it's certainly not harmful.
Excellent. So the next question is, for me, activities such as kneeling causes or adds additional knee pain. Is the activity causing more osteoarthritis and should be discontinued, or is it a live with it kind of ordeal?
So I think that anything that you do that you recover from, like if you kneel on your knee and maybe it makes it irritable for a day, you rest and it gets better, that's usually not going to be cause long-term damage. I think the things that really accelerate arthritis are injuries like fractures and ligament tears. So that's what we definitely see arthritis coming from. That does come off of a really important topic, which is kneeling and osteoarthritis. A lot of people have problems kneeling when they have knee arthritis, and it's a coin flip as to whether that gets better or worse after knee replacement surgery. So one thing I never promise people is that they say, "Oh, I can't kneel. Will I be able to kneel after surgery?" I say, "I don't know. It might get better. It might not."
And then the question is, what is a good knee brace? Are ones with copper better? I only need to wear one while skiing or hiking.
I'm not aware of a benefit of copper being beneficial one over the other. The only knee brace that is superior is if you have a deformity, like Dr. Lara mentioned earlier in the talk, that is a unloader brace. Those, though, at least in my hands, compliance, nobody really likes wearing them at all.
Yeah.
So what I tell people is pick whatever knee brace feels like it's helping you and is giving you the support that you need. You can try a couple of different ones, but there's really not, other than those unloader braces, there's not one that has been shown to have superior benefit.
Yeah, the best brace is the brace you wear.
Yeah.
Because the fancy brace is not going to work if it's in your drawer. When people complain specifically of instability, I will often prescribe them a stouter brace with struts on the side and a hinge between those struts. But Other than that, it can be a process to get a custom knee brace. So I often kind of nudge people and say, hey, try the one from the drugstore, see if it helps. If it's really not helping, if they're really interested in a custom brace, or if they're having instability symptoms, we'll pursue that. But I don't really push people to do that unless they're very interested in it. It's all symptomatic treatment. If it works, it's great. But it's certainly not going to cure your arthritis or prevent it from progressing. It's just something that's going to make it potentially feel better. I don't want you to break the bank for that if you're not really interested in it, basically.
So the next question is, what about a 3D knee replacement?
Oh, they're all 3D.
So I would agree. They're all three-dimensional. Is
Yeah.
it they have a pre-made like CT scan 3D printed?
Yeah, the question is, what about 3D knee replacement?
Okay, I think this is a big topic in joints, which is marketing. So if people that have done fellowships in joint reconstruction aren't sure what you're talking about, then this is probably something in the realm of something that's not very different than what's on the market. It's been on the market for years, but they're trying to reach out to a new patient group to try to get people to ask for that implant. And this happens all the time. Just like, drugs are directly marketed to consumers now on, commercials during the nightly news and stuff like that. This is leaking into the joints world. So there are cementless implants that are 3D printed for total knee. That's not for everybody. And there's a big debate on who should get a non-cemented total knee or not. And that's the conversation you should have with your surgeon. Those 3D printed cementless total knees, they're relatively new. They don't have the same track record as cemented knees. We're really getting in the weeds with this. But to me, the message with that is, yes, that might be a good implant. It might not be a good implant for you, but find a surgeon who can answer your question about that and talk to you about why they would or wouldn't use that for you. So that might be a great implant for a young male who has really good bone stock, and a terrible implant for a 75-year-old lady.
So you kind of mentioned it, Dr. Lara, but what about those patients that, you guys are both fellowship trained? Why does that matter? What's important about that to patients for them to know?
For me, it's like if something goes wrong, it takes care of it. That's the biggest thing. Lots of people do joint replacements. Lots of people do a great job with it. There are surgeons out there that did fellowships in other subspecialties like sports and even shoulder and elbow. They do a great job with hip and knee replacement, but they're probably not going to do the patients that are more complicated, have a big deformity of their knee, have severe bone loss of their pelvis, and most of them aren't going to do revisions, or at least most revisions. So if you fall and have a fracture around your hip replacement, that doctor's probably not going to do the revision of that. If you get an infection that requires removal of the implants and putting in new implants, they often won't do that part of it. They'll usually send it to us or somebody with a joint with a hip and knee replacement fellowship training. So it's not wrong. It's there's a lot of joints out there, and we can't do absolutely all of them. But I think that's the biggest thing to know is if your doc is not going to be the person taking care of the complication, that's something you should be aware of.
Okay, and the next question is for you, Dr. Vaux. If you've had a hip replacement 12 years ago and now are experiencing popping and intermittent pain while walking or repetitive motion, should it be examined?
Absolutely. I would say, as Dr. Lara mentioned, hip replacement is the surgery of the century. And so if your hip replacement is not doing well, you should get it examined, particularly if you had a period of time where it was doing well and now it's not.
Yeah, that falls in that time period. That more durable plastic's been around for about 20 years, but not everybody started using it right away. So in that 12 to 15-year range, that's where we're seeing some people, not everybody got the new plastic. That may have been smart at the time because being an early adopter of everything could get you in trouble. But if that plastic wears out, it can cause some of those symptoms, but definitely an x-ray and an exam from a specialist is the way to go.
And then the next question is, what is your timeline for diagnosis and surgery?
It can vary a lot. We get the diagnosis often just from talking to you in the x-ray. And then we have a preoperative clearance process. So one of the nice things is we have a very integrated team. So we have a nurse coordinator that coordinates the therapy teams, the nursing teams, the anesthesia teams, the surgeons, and we meet monthly to talk about how we take care of patients. And we have this thing called the hospital service, which is a group of docs and nurse practitioners that help us manage our patients in the hospital if they have any medical problems while they're in the hospital, like if you have anemia, if you have COPD, heart problems, those types of stuff. They help make sure you're safe and cleared for surgery. You've had everything optimized before surgery. If something happens while you're in the hospital, they help us manage that. So that process at a minimum takes about 3 weeks to get you through smoothly. If you're in great health and don't have any heart or lung problems, we can get it done a little bit faster. But most of the time, we're looking at about 3 to 4 weeks for a comfortable lead time from the daily diagnosis to getting you on the table. If scheduled a lot for that. I just got a bunch of new operating times, so I have early openings now that I'm trying to fill. But my partners, Dr. Jen and Dr. McGee, their practices are a little bit more mature. They're booked out a little bit more, but Dr. Vaux and I were working.
So the question is, I live in a 3-story house. Would I be able to do the stairs after a hip replacement?
Yes.
Yeah, that's a great question. And the resounding question or answer is yes. I tried to recommend that in the first week, you figure out a way to have a bed and a bath on the same floor and have one set of stairs, or like get somewhere and stay there for a couple of days until you're a little bit less sore. But absolutely, in terms of like after recovery, will you be able to do your stairs? Absolutely.
Yeah, you'll be doing them before you leave the hospital.
Yeah.
So that's part of the. So the way we get you out of the hospital is, we come check on you after surgery, make sure there's no surgical complications. Most of the time we're getting post-operative X-ray. Hospital's team looks at you, make sure they don't have any medical complications, and then a team of therapists, a physical therapists, and an occupational therapists evaluate you. Make sure you can do your activities of daily living and mobilize safely not to go home. If you're not safe to go home, you're not going home. And part of that process is usually walking 100, 200 feet with a walker, supervised, and you make sure you can do that independently, and then going up at least a few stairs. If people truly live on one level and really don't need to do any stairs, sometimes just skip that. But even if you got a couple steps going into your home, you'll be able to do some stairs before you leave the hospital.
So the next question, great question. How should topical medications be used? Routinely or occasionally as needed, preventatively, or when pain occurs?
Yeah, I mean, I have opinions on everything, but so the topical medications, I usually recommend them to people that can't take the oral anti-inflammatories. Joints are deep in the body, so and the knee is much more superficial than the hip. So I'm all for trying it. I usually recommend with a topical medication because we typically don't have the systemic effects of an oral medication, like problems with the kidney, stomach, those types of things. Yet we have a little bit more leeway to just keep using it without the worry of those side effects. So I recommend people try them for 2 weeks around the clock. So topical diclofenac that we talked about earlier, that can be dosed up to 4 times a day. If you really want to give it a shot, I say do it 4 times a day for 2 weeks, whether you feel like you need it or not. But it says not to use it for hips too deep really for that to get to, but it can be very helpful for bursitis because that's a much more superficial structure. And again, I'd say if you try it for a long time, because that helps build up the medication levels in that area. I think it makes it a little bit more effective.
Yeah, I totally agree. I think you need a therapeutic dose. So you can't just, unlike oral ibuprofen, which you can feel effects on like a headache or a joint pain in a couple of hours, you need a couple of weeks for that to get into your system, as Dr. Lara mentioned.
Yeah, and medications don't work like any medication. Let's say you have a twice-a-day medication. Doesn't go to a therapeutic level and drop all the way down. If you keep taking it, the blood levels, or the levels in your blood build over time. It's usually about 6 doses that it takes to get to a full dose, whatever the schedule of that is, or an optimum blood level or serum level of that medication. So whether you're taking oral or topical anti-inflammatories, you need at least 6 doses to get the full effect, taking it around the clock.
And now there's a great question. I know there's a surgeon in town who makes the knee replacement scar around the patella to make the knee more attractive and to make kneeling more comfortable while healing. Do you cut straight up and down? And what are your thoughts about the curved cut scar?
Oh.
This is for both surgeons to answer, please.
This is a great question. I'm not familiar with that. I cheat my incision I make it straight, but I cheat it to the side to try and allow for the direct kneeling to not be on the scar. I like straight lines, and I think patients like straight lines, so I don't make a curved incision around the patella for the skin. But every approach to the, not every, but all of us for a knee replacement use a medial curved approach around the patella inside the knee. I don't know what else you have to add to that.
Yeah, I would be, I don't know a whole lot about that, to be honest. And I think that some people do really complain of the scar as being a problem with kneeling, but I think it's really something more about knee osteoarthritis itself, because we see that kneeling is such a big problem with so many people with knee osteoarthritis. So that's the thing I don't promise anybody, regardless of the incision, because we have to incorporate old incisions in people's knee replacements often. So sometimes we're making incisions that are way on this side or that side of the patella. And I haven't seen big differences in my practice for people's complaints of kneeling after that. So, so I'd have to see the papers. I haven't seen any papers on it. So, but that's one I would need to look up.
We have a very educated audience, I tell you that.
Great.
So the next question is compare aspirin to diclofenac for pain meds.
Oh, good question. I don't know the papers themselves. I'd say probably diclofenac, just because the mechanism by which it works, I think is a little bit more effective and probably has fewer side effects. There's anything, I can't remember exactly what aspirin cream is. If it has aspirin or salicylates in it, those can have some more off-target effects, including blood thinning, than a more targeted drug like topical diclofenac. So, but everybody has different responses to these things. Sometimes Aleve works for people, and when Advil doesn't work for them. So it can be worth trying these things, and if there's not a horrible side effect to them, sometimes you'd have to do some trial and error, and can't know right away if one's going to be better than another.
Yeah, without seeing the direct comparison of those medications for the osteoarthritis, we know that diclofenac is very proven in a first-line treatment for a topical for osteoarthritis. So I would recommend that first. And if that didn't work for you, then I would consider trying the other.
Yeah.
The next question is, do you recommend PT pre-op? If so, which is better, swimming or walking?
It's a great question. There's two different distinctions to look at this from. One is physical therapy to treat your arthritis, and what is physical therapy to prepare you for surgery. So for patients with mild to moderate arthritis, physical therapy has been shown to delay the need for surgery and be very, very effective. Oftentimes, once your arthritis is so severe, and that sort of therapy or intensive therapy can certainly worsen your symptoms and your arthritis. And then in general, what you do in that is low impact activity is excellent. So I can't remember swimming and what else?
Walking.
Swimming, walking, cycling, those are all excellent. In terms of preparing you for surgery, we do send our patients for what we call a prehab or pre-op physical therapy. That is not to treat your arthritis and to make your arthritis go away and say, oh, after this one session, all of a sudden I don't need a knee replacement anymore. That is to prepare you for surgery. So it's to educate you on how to use a walker, how to get up and down stairs, the things that you're going to try to be doing while you're recovering from surgery after a spinal and in an unfamiliar environment. Those sorts of things. Yeah,
and a lot of it is to facilitate that same day discharge.
Right.
So when your therapist is meeting you, it's more like after surgery. That's more like a review and a test of your ability and your mobility rather than an education session, because you already know how to use your walker safely. You already know what precautions to have for your hip. You already know how to go up and down stairs if your leg's hurting. So it really smooths out that discharge process and helps answer questions. And I think a lot of people have a lot more confidence going into their surgery because they've had that free view of what am I going to need to do afterwards. That we try to go over with you a little bit, but that therapist is going to have, usually 30 or 45 minutes to talk just about your surgery. We don't always have that much time because we're doing your diagnosis, we're giving you education on the disease, and then, planning your surgery and then trying to give you education at the same time. It's a lot to do, even in the 30-minute visit.
Excellent. Next question is, what anticoagulants, if any, do you prescribe? What about just aspirin so side effects are reduced?
That's our favorite.
Yeah, absolutely. I would say that, dare I use the word, the gold standard for patients without risk factors is an aspirin. We all tend to use baby aspirin twice a day for 30 days after surgery. For higher risk patients that can't tolerate aspirin, or for whatever reason, we sometimes do something else. So if you have a history of blood clots or prior malignancy or other things that would put you at a higher risk for a blood clot, that's not a guarantee that we wouldn't use aspirin, but that would be important to bring up in a conversation that you would have with your surgeon to potentially change that medication.
Yeah, and the indications for aspirin are expanding and even bleeding over into other specialties, like in trauma orthopedics, where they would always use injectable anticoagulants like Lovenox. They're even starting to use aspirin there as well. So, but yeah, probably 95% of my patients from work get baby aspirin twice daily for a month after surgery.
Okay. The next question is, if you need both back and hip surgery, which would you do first?
Oh, nobody knows.
Honest.
It depends a lot. This is actually a very vigorous debate in the hip and knee replacement world, or hip replacement world, I guess I should say. Depends on your back surgery. If it's if you're dealing with a back deformity, there's a little bit of a debate about that. So if you're going to have a big surgery to correct a scoliosis or a flat back deformity, some people advocate for getting your back done first, because that's going to affect the position of your pelvis. That's going to affect where we're going to put the cup, sort of. Most of all, I want to know if you have back problems, so I can use a special, particular type of hip replacement implant that's harder to dislocate, which I use quite frequently. But if you're just having like a decompressive surgery for like nerve compression, like what they call laminectomy or microdiscectomy, the order really doesn't matter. A fair number of people that have non-stiff, non-deformed backs, their back pain can get better after hip replacement. Because if you think about it, most of the motions of the back and the hip are a concert of motions. If you think of just sitting down, flexing my hip, I'm also adding kyphosis to my spine. Standing up, reaching down for objects, it's all combined motion. So if your hip or your back is stiff, it tends to make the other one feel worse. The back surgeries for just back pain have kind of a checkered record, in my opinion. And I think most of the spine surgeons I trained with in residency would say, if you got back pain and hip arthritis, get your hip replacement done first. In people, like I said, people who don't have big deformities of the back get improvement, if not curing your back pain, greater than 50% of the time.
Great. Ibuprofen, is it safe to take every day? 600 to 800 milligrams.
Oh, we don't know because we don't know yet.
Yeah, safe. I would say no. There are a few medications, none, that don't have some sort of side effect with a long period of time.
Yeah, if you're 24, certainly. If you're 72 and you're on warfarin and you see a cardiologist and you've gotten 2 stents, probably not.
Yeah.
And that's where this gets tricky, because everybody's got a different risk profile and you have other doctors treating you. So your nephrologist would kill me if I told you it's okay to do that. So that's always a conversation I have with the patient in the office, and it's always about duration too. If you're on it for 2 years, chances of having kidney problems goes up a lot. If you're on it for 2 weeks, probably fine. But it's so individual that giving mass advice like that could get us in a lot of trouble.
Yeah. In general, stomach upset and kidney problems and then potential for bleeding are increased with anti-inflammatories, Advil, ibuprofen, Aleve.
Yeah.
So fire everywhere.
Yeah. And then bariatric surgery is a big one. I didn't mention that too. If people have had gastric bypass surgery, often their bariatric surgeons are very, very careful about avoiding aspirin and non-steroidal anti-inflammatories like Advil.
And the next great question, do you prescribe home therapy after surgery?
Generally not home therapy that comes to your house unless it's necessary in order for you to recover. We do give you a set of exercises sheet, and then the exercise you had from your therapist. And then we would recommend that you go to outpatient therapy generally around 2 to 3 weeks after your wound is healed.
Yeah, we think that's the ideal. In general, home therapy, it's really, so I have some patients that's all they could get because they were wheelchair bound before surgery. I have a patient with like a massive stroke that I did a hip replacement for. He wasn't going to be able to walk or mobilize easily for months afterwards. He's walking now, but the only therapy he was going to get was at home. There are some strange situations where people can get their home therapy covered, but not outpatient therapy covered. But in general, outpatient therapy, you get a lot more benefit, and we do that with knees. And in general, with hips, we almost never do therapy after hip replacement. It's generally not needed. But I have seen anecdotally, people who go to therapy in the outpatient setting get a lot better range of motion than people who are in the home therapy setting. It's just a different set of priorities in home therapy. This is often patients that have been admitted to the hospital for something like a cardiac arrest or something who are really going to be homebound. And most people going through joint replacement are not going to be homebound after surgery.
And then the question is, with diclofenac, the recommendation is a lot of cream. It is difficult to rub in the large amount. Is there a technique I should use? And what about letting fabric touch the cream? I use my arthritic fingers and thumb to rub it in.
Okay, well, you get an extra dose for your fingers.
Yeah.
It was actually invented for hand arthritis. I don't have great advice on that. Besides, it's any kind of topical medication is a very messy process that is very hard to control. So I would let it dry before letting the fabric touch it. It's gonna get on your hands, and if you have hand arthritis, that's just maybe a little extra therapy. Was another part of the question, how much, a lot?
Yeah, she said it's difficult to rub it in if she's required to do a large amount.
Okay, I'm not sure. I'm not sure about guidance as far as just the amount goes, but certainly a liberal amount of it is good. And if you have the opportunity to let it dry and absorb over time, it really does sink in. So just, leaving it on there undisturbed as long as you can. I'm not sure about particular time frames, probably about 30 minutes would be ideal before rubbing it off or anything like that.
The other thing I would add to that maybe a follow-up or a question would be, it's okay to have somebody else apply it.
Oh, yeah.
If they were, they can wash their hands or whatever when they're done. So not to put somebody else on the hook to do it for you, but it's safe for somebody else to apply it even if they don't have arthritis. Right.
And then the last question in the chat is, my hip pain came on very quickly, like in 2 months. Now I have trouble walking. Is this a common scenario? I do have osteoarthritis.
Yes.
Yeah, absolutely. We kind of have that inciting event, and then I describe it as kind of a stepwise down, meaning like you'll have your events, you may or may not get better. You make a big drop, you kind of plateau, whether that's in agony, like the person's asking this question, or it gets a little bit better and then it can get worse. But absolutely, it can be this. I don't even know what happened. I was walking up the stairs and twisted wrong, and it flares up.
Yeah, I had a doctor I worked with at my training who used I call it the heart attack analogy. People get a heart attack, they build up plaques from cholesterol in their coronary arteries for years and years. Never feel a thing until they have that plaque rupture, and then all of a sudden they have crushing substernal chest pain. It's sort of a similar thing as we talked about. You don't feel that cartilage wearing away. What you feel is suddenly you hit this, the cartilage wearing away lowers your threshold for joint inflammation. So suddenly, when it used to take running a marathon to make your knee get swollen, all of a sudden just walking up the stairs does that. And often it's an insidious or a seemingly innocuous thing. You take a little stumble, you did some gardening all day, something like that, and then your knee hurts like heck, or your hip hurts like heck, and it doesn't go away. So we see it all the time.
And I think that's it.
All right.
So I think we both can agree, you two, that this is quite the very educated, sophisticated capital audience.
Great.
So
Yeah, excellent question.
So there's one more. I get this question all the time. It's, will my knee or hip replacement set off the metal detectors in the airport?
Yeah.
And the answer is probably. You don't need a card from us. You just tell the TSA person that I have a replaced hip or knee. They'll send you to the X-ray thing rather than the metal detector. I say probably because I've had patients that now some of these implants are made out of slightly different metals, and certain metals are picked up by metal detectors better than others, and some metal detectors are more sensitive than others. And I've had patients say, well, it set it off in Cleveland, but not in St. Louis. So some variability. But if you just tell them in advance, it'll save you a lot of time talking to the TSA agent.
The other actually sister question to that, this might be too much, but are they MRI safe? If you need an MRI later, and absolutely, with very rare exceptions, they are MRI safe.
Yeah.
Well, thank you, Dr. Lara, Dr. Vaux. Appreciate it. For those of you who are still on, if you could just contact our patient-centered access team, the phone number is listed on there. Email if you have any questions as well. Happy to get you scheduled in with the consult there for Dr. Vaux, Dr. Lara. That does conclude our seminar for today.